Hi, everyone. My name is Laura Shue, and on today's episode of Shue If I Know, I want to talk to you all a little bit about IUD insertion. And before I do that, here's a brief glimpse of my professional background, which any of you can get from visiting LinkedIn. I think what I would call out is that my area of core expertise really lies in healthcare information, how it moves into the continuum, how it's used, and then how studies and research in healthcare are conducted and how they end up influencing the information that's available to us in LLMs, in your basic internet search engines, and how that shapes the public conversation. So here's the good news about IUD insertions, and that is about a year ago, CMS has added it to its standards of practice that pain management around the IUD insertion procedure should be individualized, but the discussion should be happening. There should be a discussion with patients now that, hey, this actually can be my favorite word, uncomfortable. I have some different words that I would choose to use. And this is not an anti-IUD discussion. I have had many IUDs. I would happily have them again. That's not what this is about. And this is not to impugn the research process because peer-reviewed medical research, it's the gold standard. It's the best that we have, but we still have a long ways to go. And we're not going full cold water blue jeans just yet. Okay. So managing discomfort for IUD procedures. I don't know, you may or not hear my children screaming in the house. I have tried to record this in the house several times and I had to move outdoors to get some peace and quiet don't worry, there is a qualified adult in the house with them right now. Okay, so managing IUD discomfort there's that word again, discomfort for the IUD procedure. Notice that it calls out, there's numbing medications, there's cramping relief, a lot around communication and emotional comfort, which I find curious because it is a medical surgical procedure. Um, but there is some mention of numbing medications and cramping relief, which wouldn't even have been on the agenda a couple of years ago. But I want to explore that communication, that emotional context, and that verbal support a little bit more. And I got curious because it's not like there's nothing on the male side that's comparable. How, vasectomies. I got curious. How are we talking about in everyday language? So this is Google around managing vasectomy, verbal analgesia. So the search was verbal analgesia for managing vasectomy procedural pain. And it talks about what verbal analgesia is, but I really want to know that in this context, verbal analgesia is noted to serve as a complement to local anesthesia. There's no suggestion that men should be going in for their little snip and clip with nice, reassuring words and nothing else. So hold on to that for just a second. Some of you are probably saying, well, is a vasectomy really comparable to an IUD insertion? So, okay, well, there's a couple of different ways that we could measure that, but let's take a look at what Copilot had to say about each. 10 to 30 minutes to complete a vasectomy, depending. It's a quick outpatient procedure, and the actual intervention lasts 10 to 15 minutes for most patients. Okay. Note that we're making a small opening, then cutting and sealing and blocking access to the vas deferens. Okay. An IUD search, which by the way, there are many steps to an IUD insertion. I'm not going to get into all of them, but at the end of the day, it is a surgical procedure and IUDs work. There are two different kinds of IUDs, and they work fundamentally by causing an immune system reaction to a foreign body in the uterus. So put that in your back pocket for a moment. Okay, so now we're up to a procedure that lasts 30 to 60 minutes, with the actual procedure itself taking double the time of a vasectomy. So why are we still not just having analgesia and anesthesia as the standard of care. Getting a little more curious here. Oh, and noting too, most people experience mild or moderate cramping. That study, though, reviewing the studies and chasing that mild to moderate cramping, I might make that a different episode. But hold on, I'm going to chase down this verbal analgesia business first. All right, so what is verbal analgesia? It's using reassuring words, calm communication, and distraction techniques to lower a patient's anxiety. Again, for a vasectomy, it's being called out as a non-pharmacological complement to local anesthesia. But now when we do the same search, verbal analgesia for managing IUD insertion pain, it gives the same description of verbal analgesia, but now we're talking about providing comfort levels comparable to. That means instead of anesthesia or analgesia. And now it's pointing out that there's clinical studies, clinical evidence backing that up. When I probed a little bit further on talking softly to men and verbal analgesia for vasectomy pain control, Google clapped back at me, y'all. Because while talking softly can help reduce anxiety and calm a nervous partner before or during the procedure, actual management of surgical discomfort requires specific physical care steps. Okay, we're calling it out. It's surgical discomfort requiring specific physical care. Why are we talking about IUD placement in that way? Because when we search for talking softly to women during IUD placement, we get benefits. It reduces anxiety and oh, those no pesky side effects like you get when you have numbing medications and anesthesia. You don't have to deal with those pesky side effects. And now we're adding some proven supports. Research highlights that verbal analgesia can be a suitable technique. So now we're talking about instead of anesthesia. Why are we talking about it? Because it's surgical discomfort. So let's take a little peek at this study. Well, there it is. It's a randomized controlled trial. That's a pretty strict standard for research. It's almost as high as it gets, and I'll talk about that in a moment. But it's a randomized controlled trial. I'm also noting that this wasn't in 1990. This was in 2021. This was 5 years ago, folks. 5 years ago. That is very, very recent when we're talking about medical research and how long it takes to hit the information cycle and then get pulled back, if it ever gets pulled back. Here's the punchline. Verbal analgesia is as good as oral tramadol prior to IUD insertion, a randomized controlled trial. Well, there we go, right? That's the punchline. That's what's getting picked up in all the LLMs and all the search engines. But what does the study actually say? The study says they put participants into two different groups. And one of them got the tramadol, and one of them got the talking nicely and softly treatment. The mean pain level, the average pain level for the people who got talked to softly and nicely was 4.5. And the people who got the tramadol was so it's 4.5 for the people who got the tramadol, and it's higher, 4.8 for the people who got verbal analgesia. Now, it's not a statistically significant difference, but here's the conclusion. The conclusion, there's no benefit in using oral tramadol. So why are we saying as a conclusion, and why this is concerning, this is what's getting picked up by all those search engines, all those LLMs that's shaping the public discourse on this topic? That's still on all kinds of websites right now, including some ones that I can pull up that you might want to take a look at what your website says. Cedars-Sinai, Cleveland Clinic, Kaiser Permanente. Verbal analgesia, therefore, can be a suitable technique. Wait. The group that had higher pain scores, the verbal analgesia group, can be a suitable technique for this process, and clinicians should become more familiar with its use. That's not what the results said, but that's what's getting reported and picked up from the study. Okay, so I talked a little bit more about, here's the hierarchy of evidence. And yes, I used AI to create this in the sense that I told it what to say, and it did produce the graphic for me. But basically, if you want to talk about rigor that's applied to a study, so you first on the very bottom end, the least credible is stuff that's not peer reviewed in the media, that's anecdote and tradition. The next step up would be peer reviewed editorials. This is not a peer reviewed editorial. This is a peer-reviewed published study of a randomized control trial, which is up ahead above observational research. There's only one rung on the ladder that's higher than this, folks, and that's when you do a systematic reviews. And guess what? This randomized control trial is now getting picked up in those systematic reviews and those meta-analyses on the subject of IUD insertion pain. And what's getting picked up is verbal analgesia is an effective tool, not its pain scores performed lower than tramadol, and we judge tramadol to really not be effective at all. That's not what's getting picked up. Here's where I don't know where to laugh or cry, though, because when something is peer reviewed, and I want to note that before the study is completed, I just want to know that a group of funders, and I don't know who funded this study, but it's at a university, so there would have been grant dollars, and there would have been then in-kind resources given from that university. Somebody greenlight this, okay, folks? I want you to imagine a bunch of people are just sitting in a room, and smart people, people with PhDs, people with MDs, people probably with PhDs and MDs, read the proposal. Hey, folks, you know what I think? I betcha that if we just talk to women real soft and real nice and gentle, we don't need to give them pain medicine or anesthesia while we insert a foreign body that causes a widespread immune reaction in the uterus. And then those highly educated people read the proposal and they said, yeah, I think we should definitely study that, right? So that all happened before the study was completed, even. People signed up. There was a principal investigator and there would be co-investigators. Somebody had the idea. And then a bunch of people said, yeah, I agree with your idea. I want to devote a year of my life studying how we can better control surgical, physical pain by talking more nicely and gently to women. It gets submitted for peer review. It could have gotten flagged there. All it would have taken is somebody in the room to say, hey, folks, I think we're kind of maybe backsliding to the time where we, did bleaches and bloodletting. But nobody said that. Or if somebody did say that, they got outvoted. And then they make required modifications after the peer review can say, no, we want you to make the following modifications. And then it gets reviewed by multiple reviewers. And there's a cycle of modifications. And that means at every step, this also could have been rejected. Magazines could have said, oh my gosh, you actually did this? And you want to publish that you did this? You sure you want to publish that you did this? And somebody said, yes, this is excellent research. So what's concerning at the end of the day is how this gets picked up in the LLMs and the search engines. Because now, this is now a non-pharmacologic pain management technique. It's not witchcraft. It's not boogery. It's not the Greek humors. No. It is a randomized controlled trial that provides evidence for effectiveness and is getting picked up in all LLMs. And this is influencing the way that clinicians are talking to patients. It's influencing the options. So I just thank you for coming to my talk today. Maybe I can do some more on some of the other elements that we talked about this, but I'm absolutely horrified because this is what's coming up now, that there is research supporting it. And when you dig deep, the research is not supporting it. So please pay attention to what you're reading. Click the links and click the links inside the links. Thank you.